التوتوريال هذا عن الريدكشن. لحظة، ظاهر عندكم الشير؟
ايه دكتور طالع.
reduction and splinting techniques.
ايه
طيب، طبعا this is more technical، لكن بحكم ظروف الجائحة وكذا this will be يعني نظري، لكن I encourage you to يعني try to، يعني إذا حصل لكم فرصة مثلا في المستقبل تروحوا المستشفيات أو وقت مثلا العملي، ممكن الواحد يحاول إنه يطبق الأشياء هذه. Reduction and splinting techniques in general in orthopedics, if you have displacement or joint dislocation, you have to put it back in place. Dislocation is only used for joints. Dislocation معناها the joint is out of place. Displacement معناها this is a fracture and both bone ends are not matching, so one of them displaced from the other. As a general rule, any joint dislocation is an emergency. It should be reduced right away. And then less urgently, you should reduce any displaced fracture to minimize soft tissue injury and the swelling. How would you reduce dislocate joint or displaced fracture? Usually you do traction, counter traction, and reverse the mechanism of injury. And this applies on all the joints, all the fractures. But there is, subtle differences in the techniques depending on the individual joint or the fractured bone. However, this is a general rule. So the goal of this tutorial, to know the principles of diagnosing joints dislocation and fracture dislocation or displacement, know how to reduce them and maintain the reduction using different forms of splint. So we'll use the shoulder as an example for a joint dislocation and distal radius as an example for fracture in the bones. So the objective when we talk about dislocation, so the student should be able to understand and know how to do different types of shoulder joint reduction. We'll focus on the most common type, which is the anterior dislocation, and also we'll learn how to immobilize the joint to keep it in place till the soft tissue heals. And also we'll talk about close reduction of Colles fracture of the distal radius, and to know how to immobilize the reduced fracture in above or below elbow cast to maintain reduction. So a lot of this is theory. However, these principles should be understood to be able to help you understand how to perform this. You have to know what's the purpose of this and what's the main principles behind fracture reduction. So we talked about this briefly. So you have to diagnose a patient either clinically or confirm it with x-rays. Always get joint above and joint below. When you have a patient with a dislocated joint or a fractured bone, you have to assess the neurovascular status before and after any procedure. That includes reduction or even splinting. A dislocated joint is an acute emergency that needs immediate reduction. If you're having displaced fracture, it depends whether this is intra-articular or extra-articular. Some complex intra-articular fractures would be very difficult to reduce closed. So most of the time, you just need to realign and splint and then deal with this surgically. However, if you have an extra-articular fracture, most of the time, closed reduction would be helpful, and this can save the patient from surgery. Before you do a reduction procedure, patient should be relaxed and comfortable. So this should be done under conscious sedation with IV medications, either sedations or narcotics. Or you can use the hematoma block. Hematoma block, when you have a fracture, there will be a hematoma inside the fracture. So what you do, you inject a needle in the fracture site, try to withdraw some blood just to make sure you're inside the hematoma, and then inject some local anesthesia. That will give the patient, partial relief of pain, and then you can do the procedure. However, hematoma block is not the best way to do it. It's better to give conscious sedation. Reduction, as we mentioned, it's done by two persons. Usually one person is doing traction and the other person is doing counter traction. And then once you do traction and counter traction for a few minutes, you should reverse the mechanism of injury. So let's say if you have a distal radius fracture with dorsal displacement, so you have to try to reverse it and push on it in the other direction. Sometimes you need to slightly exaggerate the fracture site and then try to reduce it just to overcome any overlap of the bone ends. As in each joint and each fracture has its own way of reduction. However, the general rule is traction, counter traction, and then reversing the mechanism of injury. Always remember neurovascular examination before and after. And then once you do the reduction, you have to recheck it with x-rays to see the position of the limb or the joint after the procedure. Once you're happy with the results, should you give patient clear instructions on what's the next step, either whether he's going to be followed up in the clinic or he needs surgery. So it should be very clear when you discuss with your patients. So for the anterior shoulder dislocation, as we mentioned, x-rays are very important to confirm diagnosis. Axillary review are very, very important because they will give you a clear view of the joint, whether it's dislocated anteriorly or posteriorly. Make sure the patient is comfortable, received enough analgesia and sedation. Patient should be lying supine in the bed. One person will perform traction and the other will perform counter traction. It's like in this case. So the person on the right side is performing traction in the same line of the position of the limb. And then the other person wrapped a sheet around the axilla and is doing the counter traction. So now the humeral head is being, pulled till you reach the level of the joint. And then once you reach the level of the joint, sometimes you can feel it or you can hear a pop. Then you can reduce the joint. So let's say if we have abduction external rotation as the mechanism of injury of anterior shoulder dislocation. So you do traction, counter traction, and then you reverse the mechanism of injury, which is adduction and internal rotation. And then once you do this and you hear a pop, you should recheck the neurovascular examination, put the patient in a shoulder immobilizer, either the shoulder immobilizer in the middle or an arm's length on the left side. Distal radius fracture, same principle. Make sure that the diagnosis is clear by getting appropriate x-rays. Patient is comfortable with analgesia or sedation. Patient is supine in the bed. One person pulling on the hand. So you push or you hold the thumb and make sure the thumb is lined up with the radius, and then you deviate the other fingers to the ulnar side. And then one person will do traction, the other person will do counter traction from the elbow for a few minutes till the fracture, disengages and, both fragments are closer to their position. And then you reverse the mechanism of injury. So if this is Colles fracture, that means it fractures the space dorsally. You should push the fragment in the volar direction. And then once you're happy with this, you apply the splint. So one person should be holding the distal radius in position, and then the other person applying the splint. So just to make things simple and clear, general principles of reduction in orthopedics: traction, counter traction, reverse the mechanism of injury. Always examine neurovascularly before and after the reduction. And then once you achieve the reduction, you have to maintain it with splinting. So the splint, we have different kinds. We have complete cast. We have back slab. And we're going to talk about each of them. So complete cast, usually it's circumferential all around the limb. So how to apply it? So you have to first make sure the limb is in a good position. You have to measure the length of the slab. One physician will be holding the limb in position, especially if it's a distal radius fracture or a long bone fracture, and the other will start preparing the cast. So first thing you do, you put a stock in it. It's like a sock that you cut slightly longer than the cast, and then you apply first on the skin, and then you apply soft roll around this stockinette. There should be 50% overlap, and make sure that you have good padding of the bony prominences. And then you take the plaster of Paris roll. plaster of Paris اللي هو الجبس هذا الأبيض اللي فيه غبار، تاخذه وتحطه في warm water until you see air bubbles coming out, and then you take it out. Usually it takes less than 20 seconds. And then you start wrapping around the limb over the soft roll. And then you do this and make sure you do it more than one layer, because 1 or 2 layers is not enough. It will be very weak. And then once you're happy, you can fold the stockinettes on the cast itself, and then make another roll of cast just to hold the stockinette. And then you'll have very smooth edges of the splint. When you apply a full cast, make sure it's not very tight. Make sure there's no significant swelling. I advise the patient always to elevate the hand and put ice. Back slab is different. It's a half. It's not a circumferential slab. So you do the same. You measure the length. Someone should be holding the limb, and the other one is doing the actual casting. So you put the stockinette the same way, and then and also you put the soft roll the same way. Instead of taking the roll and rolling it around the limb circumferentially, you take the roll and put it on the table, and then you fold it on itself in layers, and then you start immersing it in water, and then you apply it in the side of the limb that you want to apply to, and then you hold it with a bandage. The advantage of, so the layers should be at least 10 layers. The advantage of back slab over full cast: back slab usually allows the soft tissue to expand and breathe, especially if there is significant swelling. But the disadvantage is sometimes it will not provide the amount of stability that you would like to have. Advantage, as we mentioned, it's faster and easier to apply. Because it's non-circumferential, it allows for natural swelling that occurs during the initial inflammatory phase of the injury. A splint may be removed more easily than a cast, allowing for regular inspection of injury site. Disadvantage, lack of patient compliance because it can be removed easily, and excessive motion at the injury site. General rules for cast fixation. This is very important. You have to understand this. So when you have a fracture, you have to immobilize a joint above and a joint below to have better stability. Try not to immobilize any joint unnecessarily because that will cause unnecessary stiffness. If you are immobilizing a joint, you have to immobilize it in the functional position, and that depends on the joint. So for the knee, it's 10 to 15 degrees of flexion. The elbow is 90 degrees of flexion. Ankle and wrist are neutral position. At the wrist, stop just proximal to the distal palmar crease to keep the metacarpal or metacarpophalangeal joint free. So you don't immobilize unnecessary joint dimension and you don't get stiffness. Proximally, if you're doing a below elbow, should be 2-finger width distal to the elbow crease, just to avoid, the cast, cutting into your elbow. If you're doing above elbow, should be just below the deltoid insertion, which is around the mid part of the humerus. For the foot, if you're doing a lower extremity, distally keep all toes exposed. Proximally for below knee, should be just below the tibial tuberosity. If you're doing above knee, should be in the upper third of the thigh, just to allow for good stability of the joint. So, in terms of the material, there is plaster of Paris, which is gyps, and there is fiber glass cast or fiberglass material. Plaster of Paris, the advantage is it's cheap, easily available, versatile. So if I have a displaced joint and I want to mold the cast on the bone, plaster of Paris is better because it's very easily molded and it stays in the position that you want to keep it in. More effective immobilization compared to slab. Okay, so disadvantage of a full cast compared to half cast, as we mentioned before, so it takes more time, more complication compared to the back slab because it's circumferential, can cause stiffness of the joint if you leave it for a long time, pressure problems because it's all around and can be pushing on the skin and the bony prominences. Plaster of Paris compared to fiberglass, usually it's not waterproof, so it can be damaged by the water, and also it's heavier than the fiberglass. This slide is very important. Complication of cast. This can cause compartment syndrome if it's very tight, and also ischemia. Because of the cast material, usually it's very hot when it's curing or hardening, so can give you heat injury. Make sure you have enough padding below it. Pressure sore and skill breakdown also is common if there is no enough padding of the bony prominences and the skin. Infection also can be a problem if you have skin breakdown and you don't realize this. Dermatitis, if you apply cast immediately on the skin. Joint stiffness, if you leave the splint for a very long time. And in some cases, when you have very tight cast, can compress on some nerves and cause neurological injuries. في أي سؤال عن الموضوع هذا؟ في سؤال يا شباب؟ شوف الشات هنا. all clear، واضح كلير، ما شاء الله عليكم. المحاضرات كلها موجودة، اللي يسأل كلها موجودة عند الدكتورة ضحى. زين، يعطيكم العافية. يلا، فمان الله يا شباب.